Assalamu alaikum everyone. On behalf of Radiological Society of Pakistan, I am Dr. Ihtisham, and I would like to welcome you all in today's online journal club organized by Radiology Department, FMU and BIRSP under kind supervision of Professor Dr. Asim Shokat and Professor Dr. Amna Rehan. Our today's topic is role of strain wave elastography in the evaluation of patients with renal fibrosis with kidney disease. And our presenter is Dr. Amara. She is a resident from Sir Gangaram Hospital, Lahore. And our expert panelist is Dr. Saman Chaudhary. She is Associate Professor and Head of the Department, Radiology Department, Fatima Jinnah Medical University, Lahore. Over to you, Dr. Amara, with the presentation, please.
Assalamu alaikum everyone. Good morning. I'm Dr. Amara from 4th year Radiology PGR, Sir Gangaram Hospital, Lahore. In today's journal club, I'm going to present an article published in Nephrology 2025 that is role of strain wave elasto in evaluation of renal fibrosis in patients with kidney diseases. CKD is a global concern these days. Most common causes include diabetes mellitus, hypertension, and primary renal diseases, such as glomerulonephritis. CKD leads to renal fibrosis, which in turn leads to end-stage renal disease. Early fibrosis detection helps improve treatment decision and prognosis. Renal biopsy is a gold standard not only for diagnosis of fibrosis but also in terms of prognosis and treatment planning. Biopsy accurately measures interstitial fibrosis, tubular atrophy, and glomerulosclerosis. But biopsy is invasive and may cause complications such as bleeding. Also, we cannot do it frequently for follow-up. So this made it unsuitable for regular monitoring of fibrosis progression. And there's a strong need for alternative non-invasive tool that is ultrasound elastography. Ultrasound elastography is a modern technique which measures tissue stiffness. As fibrotic tissue becomes stiffer, elastography can detect this change. It can reduce dependency on biopsy in follow-up situations. There are several types of elastography techniques. These include strain elastography, shear wave elastography, transient elastography, and acoustic radiation force impulse. This study focuses on strain wave elastography. Strain wave elastography is a semi-static ultrasound method which measures tissue displacement caused by manual compression and decompression performed by operator using ultrasound transducer. When pressure is applied, tissue compresses more, while stiff tissue compresses less. This difference is measured by the ultrasound and is displayed visually. The output is represented by a color-coded map. Red indicates soft tissues, green indicates intermediate tissue stiffness, and blue indicates hard tissues. In addition to color images, strain elastography also provides a semi-quantitative numerical value called strain index. It is a ratio measure that compares strains between
Dr.
two
Amara, please wait. Your voice is a bit distorted. Please check your internet connection once more. Please check your mic also.
Am I audible now?
Yes, better now.
Great. What is strain wave elastography? Strain wave is a semi-static ultrasound method which measures tissue displacement caused by manual compression and decompression performed by operator using ultrasound transducer. When pressure is applied, soft tissue compresses more while stiff tissue compresses less. This difference is measured by ultrasound system and displayed visually and is represented in a color-coded map. Red indicates soft tissue, green indicates intermediate tissue stiffness, and blue indicates hard tissues. In addition to color images, it also provides a numerical value called strain index. It is a ratio-based measurement and compares strain between two regions. A higher index indicates greater stiffness, which means more fibrosis. Here we can see a strain elastography being performed with patient in right lateral or left lateral position depending upon the examining kidney. Alternative compression and decompressions are being applied. Now we have a case of acute interstitial nephritis post-chemotherapy. This is a grayscale image that shows the renal parenchymal echogenicity is raised. However, the CMD is preserved. And on the left side, we have a color-coded ultrasound elastography image in which the color code is basically green and blue. And we have two circles, which is the region of interest. One is placed in renal sinus fat, while the other one is placed in renal parenchyma. And on the bottom of the screen, we have sinusoidal waveform pattern of compression and decompression seen in the inferior aspect of the image. The main aim of the study is to correlate renal strain index values with renal fibrosis degree and to compare elastography findings with renal biopsy fibrosis grading. In other words, researchers wanted to determine if strain elastography can act as a non-invasive alternative for predicting fibrosis severity. Now, the study that was conducted is a prospective cross-sectional study and includes 68 adult patients who were referred to the nephrology unit for biopsy over the period of about 1 year. The inclusion criteria was patients which are older than 18 years and had indication for renal biopsy, such as proteinuria more than 1 gram per day, unexplained renal impairment, isolated glomerular hematuria. Now, the exclusion criteria, they were excluded if they had conditions that could interfere with elastography accuracy or biopsy, such as uncontrolled hypertension, single kidney, polycystic kidney, thin renal parenchyma, renal malignancy, active infection, or bleeding disorders. The selection ensured that the study population is appropriate both for biopsy as well as elastography. Renal biopsy was performed using ultrasound guidance from lower pole of the left kidney. All the patients were monitored for 24 hours after the biopsy to evaluate any complication. Histopathological examination was done during different staining methods, including H&E, PAS, Mason trichome. The main parameters evaluated were interstitial fibrosis percentage, tubular atrophy, glomerulosclerosis, vascular sclerosis, and G-score. Fibrosis was graded using BIRSP scoring system for interstitial fibrosis and tubular atrophy. Mild fibrosis means less than 25% fibrotic area. Moderate fibrosis is 26 to 50% fibrotic area, and marked fibrosis is more than 50%. This classification served as the reference standard for comparison with elastography. Strain elastography was performed within 3 days after renal biopsy by the same radiologist. This was done to maintain the consistency and reduce operator variation. The equipment that was used was Toshiba Eplio 500 ultrasound system with 3.5 to 5 MHz convex probe. During the procedure, the operator performed 7 to 12 gentle repetitive compressions to create sinusoidal compression-decompression waves. The ultrasound screen displayed 3 windows: grayscale, color-coded, and compression wave display. Two ROIs were placed at the same depth, one on the renal sinus tract, which acts as a reference region, and the other one on renal parenchyma, which is the target region. And the strain index was automatically calculated. The mean of 3 measurements was used for statistical analysis. Now we have another example of necrotizing glomerulonephritis with marked interstitial fibrosis. Grayscale image shows markedly raised renal parenchymal echogenicity with poorly demarcated CMD. The left one shows a color-coded ultrasound elastra image and is mainly blue-green scale, and sinusoidal wave of compression and decompression is seen here. There are two ROIs. This is the reference range and this is the target area. And here the strain index comes out to be 3.17. Now, this is a ROC curve between sensitivity and specificity of the different parameters such as echogenicity, qualitative elastography, semi-quantitative ratio, which is strain index, and reference line. This curve shows that the parameter which is more toward the left side is more specific and has more area under the curve. And in this case, this is the semi-quantitative strain index, this one. So this is the more specific parameter. The 68 patients that were enrolled in this study were divided into three groups according to biopsy fibrosis grade. Group 1, mild fibrosis, Group 2, moderate fibrosis, and Group 3, marked fibrosis. There was no statistically significant difference between age or sex between these groups, meaning the groups were comparable and fibrosis severity was not based by these demographic variables. The study shows significant difference between groups in shows no significant difference between groups in renal function markers. Patients with more severe fibrosis had higher serum creatinine, higher blood urea, and lower eGFR. And this demonstrates clear relationship between fibrosis severity and worsening renal functions. Histopathological examination also revealed that when fibrosis increases, there's also increase in all of these parameters, such as tubular atrophy, percentage of fibrosis, G-score severity, and number of sclerosed glomeruli. Elastography findings were highly significant across these fibrosis groups. There were clear differences in echogenicity, qualitative elastography color patterns, and semi-quantitative strain index. As fibrosis is increased, kidneys appear more echogenic and elastography pattern shifts from red-green toward blue-green. And blue indicates increased stiffness as fibrosis makes tissues harder and less compressible. One of the most important findings was the significant increase in SI values with fibrosis progression. In mild fibrosis, value it was 1.1 plus minus 0.50. In moderate fibrosis, it comes out to be 2.6 plus minus 1.62. In marked fibrosis, SI value is 2.8 plus minus 0.9. This means that patients with moderate or marked fibrosis have significantly stiffer renal parenchyma compared to mild fibrosis patients. SI was therefore strongly linked to fibrosis severity. Spearman correlation analysis shows that all the parameters which are mentioned in the previous slides has positive correlation with lab findings such as serum creatinine and blood urea, as well as with the biopsy results, which include percentage of fibrosis, G-score, tubular atrophy, and number of sclerosed glomeruli. However, there is a negative correlation with eGFR. This is clinically important because it indicates that elasto findings are in line with biopsy and lab findings. Previously, I have briefly explained about ROC curve. This study used ROC curve as an analysis tool to study the accuracy of strain elasto in diagnosing fibrosis. Sensitivity, specificity, and area under curve of echogenicity, uh, qualitative elastography, and SI were plotted. And this shows that the semi-quantitative SI has the highest specificity, which is 93.8%, and therefore is a strong predictor for renal fibrosis. Binary logistic regression analysis was performed to identify predictor of fibrosis. The analysis shows that echogenicity was a significant predictor, so is the semi-quantitative SI, but qualitative elasto was not statistically significant. This suggests that strain index and elastography are more reliable than the color interpretation alone. The following elastography parameters differ significantly between the groups, that is echogenicity, qualitative elastography, color scale, and semi-quantitative SI values, which mean more fibrosis, more stiffness, more blue-green areas in higher SI. Mean SI value is, as I have previously described, mild fibrosis is 1.1, moderate is 2.6, and marked is 2.8. And it increases as the fibrosis is increased. Now, what is the clinical significance of strain elastography? Strain elastography is a safe, non-invasive method. It provides measurable information about the stiffness. It could help in monitoring CKD progression, evaluating fibrosis without repeating biopsy, improving follow-up assessment, but biopsy remains the gold standard for the diagnosis. What are the advantages of strain elastography? It is non-invasive, there is no radiation exposure, it can differentiate different stages of fibrosis. It is easy and fast, and it is also used for follow-up monitoring. What is the limitation of this study? Limitation is it's a small study, only 68 patients were enrolled in it, and it is done for shorter duration and no long-term follow-up advice. Elastography is highly operator dependent, and compression result may vary between different individuals. Depth of the native kidney may also reduce accuracy compared to transplanted kidneys. Now, what is the conclusion? Strain wave elastography is useful in evaluating renal fibrosis. SI values strongly correlate with biopsy fibrosis degree, and it can distinguish mild, moderate, and marked fibrosis. It can become useful tool for follow-up, but renal biopsy is the gold standard. Now, the take-home message is renal fibrosis causes increased kidney stiffness. Strain elastography is a promising non-invasive method, and the strain index is a reliable indicator which is linked to fibrosis severity. Further research is needed before routine clinical use. Thank you.
Thank you, Dr. Mara. Over to Ma'am Saman for concluding remarks, please.
Assalamu alaikum. Thank you so much, Dr. Tisham, and thank you so much, Dr. Amara, for discussing this interesting topic with us about this novel technique of elastography. Well, we all know that elastography has evolved over the last few years, and it's being widely used in various areas, particularly in liver for liver fibrosis. We know that it's been widely used in differentiating benign and malignant breast masses. And it's being also used for the differentiation of benign and malignant lymph nodes. So much so that it's been used in areas like uterus for differentiating fibroids, adenomyosis, for endometrial carcinoma, and for cervical incompetence, even for preterm labor. So, this is another area for depicting renal fibrosis. We know that daily lots of patients come to us with renal parenchymal disease, and obviously, we have to perform biopsy in most of the patients for the degree of fibrosis. Now, my question is that can we replace biopsy with elastography? As you have already mentioned, that no, not at this point, and we obviously need more research. The results are promising, as you've mentioned, that the degree of fibrosis was directly related to the value of strain index you calculated. And Dr. Amara, did you mention that we've started doing this in our department since we have elastography available with us? The only problem is that elastography software is not available at most of the hospitals and departments. But we are doing our own studies, and we need studies with larger number of patients, and we need better results. But I'm sure that the results will be promising. I think the most important use could be in picking up the patients and selecting patients for the biopsy. You know, Amara, did you mention that when do we do this elastography? Are we doing in all the patients, or how do we
Um,
select the patients?
Benab, this was a pilot study. So in this, all the patients were sent for renal biopsy to confirm the fibrosis. If we performed it on a larger scale, then we can definitely make it as a standard, and it could replace renal biopsy in some cases
Okay,
in
how
which
do we pick?
biopsy is contraindicated.
How do we pick that in which patient we have to do elasto? We are doing it in every patient. They did it in every patient.
Madam, in every patient, except there are certain parameters in which biopsy is contraindicated, such as uncontrolled
Okay.
hypertension or in patient with renal parenchymal diseases.
Okay, no, I mean they did elastography in all the patients, even if it was grade one parenchymal echogenicity or grade two or grade three or whatever. They
Yes,
did
madam,
it
in
in all
all.
types of patients, and then they performed a biopsy, and then they compared the results. And the strain index was directly related to the degree of fibrosis, right? So it's a very good tool, at least for follow up for now, until we establish the role that if we can replace the biopsy or not. So the main use right now is to picking up the patients like those who have advanced stage of fibrosis. And I mean, what do we do after biopsy? Now, basically, we have to help managing the patients. So if it's end stage fibrosis, I'm not sure what's the advantage of doing a biopsy in that patient in end stage, because in those cases, performing an invasive procedure just to confirm the stage of the fibrosis, I think we can avoid that. just by performing elastography. What do you say?
Yes, madam, it is a useful tool in picking up early fibrosis, such
Yeah.
as a lot of patients came to us with diabetes for KUB ultrasound. So if this technique is available, we can not only infer from echogenicity of the renal parenchyma, but we can also provide the degree of fibrosis that these patients have. Like if there is mild fibrosis, we can definitely help the clinicians in better planning their treatments and prognosis.
So basically, the main aim is to prevent progression of the fibrosis if we can pick it at early stage. So that's
Yes,
basically the
ma'am.
main use, right? So I mean,
Yes.
just documenting the stage of fibrosis, that's of no point, now. Basically, the important thing is to manage the patients, and if we pick fibrosis at an early stage, that's going to help patients.
Yes, madam.
I hope that's clear now. Okay, any questions? Okay, there's a question about the facility. Yes, there is a facility of elastography in Gangaram, and we have already conducted many workshops on elastography at Gangaram, and hopefully we'll perform many more in the near future. Stay in touch. Any other question?
No, ma'am. So far, we only got one question, and you have already answered it. Someone is asking how much pressure is needed.
Well, you saw that curve in the third inside the box, the sinusoidal curve. When you apply pressures, you need to see the shape of that curve. It should be at a certain, it should fill the box. There is a yellow box on the right side of that curve. When you are applying adequate pressure, that box fills in. So that shows that the pressure is adequate. In order to learn the proper technique, you have to do hands-on. This cannot be properly explained in these kind of presentations. So you need hands-on workshops for that. But that yellow box that fills in when you apply adequate pressure.
All right, ma'am. Thank you so much. And that
Thank
concludes
you.
our today's
Thank you so
online
much.
session.
Thank
Thank you so
you.
much.
Thank you.